Good afternoon. Welcome to Grand Rounds today. Before we get started, quick reminder that there will be no Grand Rounds next week or the week thereafter. But then hopefully we will reconvene after the first of the year. Today, I have the pleasure of introducing Emily Fecht. Emily received her Master of Arts in Speech Pathology at UNI and has been on the staff at Mary Greeley since 2013. She has graciously accepted our invitation today to update us on a review of speech and language pathology. And please join me in virtually welcoming Emily. Thank you.
Thank you. Thank you for that applause up there. All right, so today it's going to be kind of a general overview. So like you said, I'm Emily Fecht. I'm one of the speech therapists here at Mary Greeley. I've been here for about 7 years. I work inpatient and outpatient, and I would say primarily during this COVID time, I've been in the outpatient clinic, learning a lot about telehealth and working with some of those patients that really need our services because without them, they may end up in the hospital themselves. When I'm giving the presentation today, I'm going to kind of split it up into the hospital side versus the outpatient side. So the first half, I'm going to kind of focus on what we would do in the hospital. All right, at first, I kind of want to talk a little bit about who's on our team. So we have 5 different therapists, and if you look at who they all are, again, myself, so I'm in the inpatient and outpatient side. We have Greta Goodman. She used to do a little bit of outpatient, but now during COVID, she's kind of all on inpatient side. Christine Sinke, she's inpatient as well as outpatient. We have Melinda Lsvt. She does some outpatient, and in the outpatient clinic, she would also be our peds therapist. So she could work on some of their language disorders if they're a little bit delayed with some of those speech components. She also does home health. Not sure what our radius is, but I know it's, she does a lot of around the Ames area, Ankeny. I'm not sure how far she goes. Amanda Furland, she works on acute rehab, and she's actually a rehab care employee. However, we really try to help each other out. So sometimes we may go down there and help her, and sometimes she helps us out in the hospital. Okay, so the next thing we're going to talk about today is kind of what type of patients do we see? What deficits do they have? So a big part of what we do, especially in the hospital, would be swallowing deficits. You'll see the term pop up a lot, dysphagia, and that's what that means. It's just swallowing deficits. It can include a variety of things. We also would help patients that have speech or language deficits. We do a lot of cognitive therapy, voice therapy, and augmentative therapy. We'll get into more of all of these in a minute, but that would be speech-generating devices that they might be using for augmentative therapy. Okay, let's look at this picture. So this is probably what most of you would think we do. We come in, we help that patient in the hospital with eating, we'll help them any strategies they may need, and that's all we do is swallowing. Though we do a lot of that in the hospital, there's some other things that we focus on too, which we'll get into. But we're going to start off by talking about this particular issue of swallowing disorders. First, I want to talk about why would we do a referral? What would be an appropriate referral? And in the hospital, it might look slightly different than in the outpatient setting. So on the inpatient side, you might see that patient reporting, that they feel something kind of stuck in their throat. I guess if you feel like you ever swallow a pill and it's not going down the right way and you kind of feel it stuck there, a lot of times that's what the patients will report. They just feel like that meat sticks right there and they can't get it down. They could complain of other swallowing difficulties, such as difficulty chewing or getting food from the front to the back of their mouth. They could also have a history of being on an altered diet. So maybe at home, they're eating really soft foods. They might need pureed foods. They can't chew bread, things like that, they may tell you. They also could have a history of recurrent pneumonia. So those are all kind of on the patient side. What could staff observe? Why would they want to place a referral for this patient? Well, they do a bedside screening usually upon admission. And during that screening, if that patient shows signs of aspiration, which would usually be coughing or lots of throat clearing, then they would refer to us. Also, if they had a diagnosis of pneumonia, that could be a good indicator. Sometimes they'll have anterior loss. What does that mean? Well, that's if they're eating or drinking and a little bit of that food or liquid could kind of spill out of either the side of their mouth or the front of their mouth. Maybe they just can't quite get their lips a good seal there. They could also have prolonged mastication, essentially just chewing for a long, long time and it won't get chewed up all the way. Pocketing or oral residue is another observation frequently seen, and that means they might look like a chipmunk. Maybe they'll kind of save some of those leftovers, keep them in their cheeks. We could also see when they go to open their mouth to talk that they just have a whole bunch of food or liquid all over their tongue. They may have a lot of coughing observed, or a drop in O2 sats. So we try to look at that, typically below 90, but those COPDers, maybe below 88 would be a good indicator. Another thing that I didn't put on here would be, sometimes I'll walk into a room and the person could be really lethargic, they could be out of it, they could be confused or overall weak. And those can also affect the safety with swallowing. If a person is really confused and they're sitting there trying to chug their water and they're coughing uncontrollably because they don't really know what they're supposed to be doing, we may need to help them figure that out. Okay, here are some diagnoses that we often see related to dysphagia, or that could have dysphagia. Stroke, lots of times. Parkinson's, ALS, myasthenia gravis, dementia, head neck cancers, really any neurological degenerative disease, and also, I want to say, aging process. As we age, if you think about it like this, lots of times there's going to be patients we have that need a knee replacement or a shoulder replacement. If they need a knee replacement, why could that happen? You've used your knee a long time. It can wear out. Same thing can apply with the muscles in your throat. So as we've swallowed for a long time, those muscles may need to be strengthened again because they're worn out. Okay, once we've gotten that referral for swallowing, what are we going to do with it? We could go one of two ways. We could either do a bedside evaluation or a swallow study. So what we're going to start off talking about first is what we can do at bedside. When I get an order and I want to go in and do a bedside swallow, I kind of try to go through a series of different things. The first thing I would do would be a good case history. I want to be thorough. I want to get that background. I might look at a chest x-ray in the chart, see kind of what's going on. Do they have pneumonia? Where is that located? I'm going to also look to see if they have a history of recurrent pneumonias. Maybe they had a previous swallow study. What diet were they on? What was the recommendations from that? When they were at home or a care facility, were they having a history of like an altered diet? Maybe they were on pureed foods and we need to get that information. One last thing that sometimes I've run into too is, do they have a history of a stricture requiring a dilation? So a stricture really is essentially narrowing of the esophagus. And oftentimes when people say food gets stuck, it's hard for them to determine where that's happening. And so if I start to see them at bedside and I'm able to maybe determine, oh, this looks like it's more of a GI concern than it is swallow, maybe I should refer them on to GI. Next, I'm going to do an oral motor exam. So for that, I'm looking at all the structures of their face and neck. I'm looking at the strength, the coordination, checking for any sores in their mouth, especially with our cancer patients. That radiation can cause some pretty good sores in their mouth. Look to see if they have teeth. Are they missing any? Maybe they have dentures, but they're not there with them. Simple things. Do they need adhesive to hold their dentures in? I mean, sometimes it can just be as simple as that. Next, I'm going to look at assessing how they do with eating. So I'm going to be giving them some different consistencies of foods and liquids and really try to listen for signs of aspiration that we'll get into. And also feel, is their larynx rising how it should? Are they throat clearing a lot? What are they telling me? Does it hurt? Does it feel stuck? Again, I'm going to look at those O2 saturations, and then I'm going to decide, where do I go from here? Is this enough? And do I get enough information that I can determine what they should be on? Or do we need to look at doing a swallow study? We also sometimes, on occasion, I used to work with infants a little bit more than I do now. I can't say I'm a huge expert in that area, but in the past I used to work with some different infants. And really what we do with them when we're checking for swallowing deficits is we work closely with the nurses. The nurses, the dietitian, the doctors, and the families. The moms know them really well. We've got to listen to what they're all saying. When we're looking at that child, we want to look at their demeanor. What are they like when they're eating? Are they crying? Are they turning blue? Are they gagging, coughing? Do they have a drop in their O2 sats? Are they vomiting? Could it be a sign of reflux? Are they flailing around and they just can't control what they're supposed to do when they're swallowing? So again, we'd kind of get that whole picture and decide, where do we go from here? All right, so the other swallowing test that we could do besides the bedside would be a swallow study, and it's actually called a video fluoroscopic swallow study. It's a mouthful. And why would we do this? Well, if I saw that person at bedside and I really want to determine, are they coughing because they just are coughing? Maybe they have allergies. Maybe they have reflux. I'm not really sure. Then I might do the swallow study to help me determine if it's truly going into the airway, if it's aspiration pneumonia. This is going to be a more objective assessment to look at the oral and pharyngeal phases of swallowing in order to determine the safest yet least restrictive diet. We want someone to be safe, but I also don't want to put somebody on thickened liquids that doesn't need to be, and they don't want that either. We're going to rule out silent aspiration. Silent aspiration, what that means is they're having food or liquid go into the airway, but they don't have a cough response. They don't have any throat clearing associated with it. So we can't really see that at bedside. That would require a swallow study in order to be able to determine that. We also want to determine, can they eat safely orally, or do they possibly need a feeding tube? I can get those results, and then usually I work closely with the doctor to get that ordered and have that placed. We also want to determine the best swallowing strategies. In talking about swallowing strategies, it's really important to know what I'm giving one patient is not necessarily going to work for the next one. So oftentimes, I've worked various places. I worked in Des Moines before I came here, and I worked closely with the nurses there. And you would hear them commonly say things like, all right, you can't swallow, go ahead and just tuck your chin. That's going to help you get your pills down. Tuck your chin, that's going to help so that you don't have any aspiration. So go ahead and just tuck your chin. And they'd kind of tell people that all over where I was working. Though they were trying to be safe, they were trying to really help these patients, but sometimes when I've done a swallowing study, it actually makes it worse. So there are times when, if we're telling people to use these strategies, we're actually making the problem worse. That is only one strategy, and that only works for some people. So it's really important that when you guys hear us telling you strategies to use, that we use the ones that we told you. All right, let's look at the next slide here. It's kind of supposed to be like the room in radiology. It's not ours, but it's similar. So you'll see this huge table there, and we turn that to the side. We'll put our patient in their wheelchair, or in this other chair, I like to call it the pink throne. So we put them on that, and then we place them right next to this tall table, and on the other side is the camera. So they're kind of wedged in there. In the room, when we're doing a swallow study, we're going to have the patient, the speech therapist, the radiologist, and I can't forget my rad tech girls. They are often there, and they help me position the patient. Sometimes they're nice enough to set up for me or clean up for me. Often during a swallow study, I might have a patient tuck their chin or use different strategies, and they'll get them in the right position for me. I'll have my patient sit in a chair, and then I'll give them some various textures that have a little barium with them. Typically what I do, I think most of us do, is we'll start with more of a pureed food and work our way up to more solids. Obviously, only going as far as we can with that patient to make sure that they're safe. So I may give something like applesauce, then pudding, then peaches, graham cracker, and finally some trail mix or peanuts. I know my radiologists out there, you're not loving me that I give peanuts, but we got to try a hard texture. The next thing we want to look at during this test is swallowing strategies. So for swallowing strategies, again, it depends on what we see. If we see a lot of residue, we're maybe going to try a strategy like having them swallow really hard. We call that an effortful swallow. Swallowing twice. Alternating with liquids. Those are some of the things for residue. Chin tuck can sometimes help again with penetration or aspiration. We'll get a little bit more into these in a minute. During this test, again, it's going to follow kind of that oral phase, pharyngeal phase, all the way to the level of the upper esophagus. So at that point, we call that the UES, the upper esophageal sphincter, and that would open as the patient is going to swallow. Anything below this level would really be more of a GI consult. They're going to be doing an esophagram or a different test to look at that esophagus. One last thing I wanted to say in this part was when we get those patients down there, you have no idea how many times I get patients and I go to give them their first bite and they don't have any teeth. And they were supposed to have teeth. They had them upstairs, but somehow they didn't make it down. So one of the big things we want to make sure of is I don't really love to have to call and make everybody wait to get dentures. So if we can try to make sure and see if they have dentures prior to that swallow study, and adhesive if necessary, because often they just don't stay in and they're wobbling all over the place. All right, this next slide looks overwhelming, but I want to show you some examples. So there's going to be a couple of swallow studies. We're going to look both at the normal swallow study and an abnormal swallow study. Some structures that I want to point out, let's see if this works here. Yeah, you can see that, right? Okay. So I want to show you on this normal swallow study, there's a couple different structures that I can point out just so you have a little bit of info. There's kind of a long little thing right here that curls around. Can you see that? That's the epiglottis, okay? So it has a job. Really, as you swallow, what's supposed to happen is that goes down. So think of it kind of like a drawbridge. It'll go down and close off. There's two tubes down here. In the front, right here, kind of this white space here, that's your trachea. In the back is your esophagus. Right now the esophagus looks dark, and that's because it's closed off. It would open up when the food or liquid gets down to that part. As this epiglottis goes down, it should cover off the entrance to the trachea, essentially making that food and liquid steer back towards the esophagus side. You'll also see this little kind of like ball shape. Do you see that? Okay, so that's going to be your hyoid bone. If you think of it, I kind of describe it like a hinge. So you have this little hyoid bone, you have your epiglottis, and they're going to work simultaneously. As one moves up, the other goes down. So it's going to have this pulling effect where they work together. That's really a lot of what I'm going to be looking at when I'm doing one of these swallow studies, in addition to lots more. But if either of those two structures aren't moving how they should be, we're probably going to see a deficit. We might see penetration, we might see aspiration. The other thing that we might see a lot of would be pharyngeal residue. If you're not having your epiglottis go in a downward position, number one, you're not going to be covering your trachea, so food and liquid can get in there. But number two, it's going to be holding on to a lot of that material. If you think of a cup that has liquid and you try to just turn it over a tiny bit, what's it going to do? Hold on to all that liquid in the cup. Essentially, it's the same thing. So let's look here at the first one. So we want it to go down that back side, not into the trachea. Beautiful. There's not even much residue there. Now, if we look at the second one, you're going to see at first that it starts to go down into the esophagus, but then after that, you kind of start building up some residue, and it'll trickle over into the trachea. Give it a second. So that looks okay so far, right? So now let's go back. And you can see a lot of it just went into the front there, into the trachea. You can also see that that epiglottis is still pointing upward. It didn't invert at all. So you don't have any protection there, and you're going to have a lot of residue at the end of that swallow. Why do we care so much about residue? I think we care so much about residue because as it piles up more and more, eventually some of that can trickle over into the airway, and that too can cause pneumonia. This is another one where I think it's just a little bit easier to view that aspiration. So you'll see that material enter into the trachea here in a larger amount. That's pretty obvious. Okay. Now, I would say definitely, by far, when we look at a lot of these, I picked ones that you could really see it, but there's a lot of times where I'll have to replay these because I'm looking at so many different structures and you can't identify stuff very well, so they're not normally this easy to see, but I wanted to show you guys some good examples today. Okay, let's look at swallowing treatment. So when we're working with these patients, what are we going to do to help them now that we know that there's a problem? Number one, I'm going to educate staff. I want to talk to staff about, what are they doing? What are you guys observing when they're eating? I'm also going to make a green sheet. So no matter which type of swallowing assessment I do at bedside or a swallow study, I'm going to have a green sheet. And we hopefully remember to do these in most all patient rooms. But these are going to go up on the whiteboard. This is going to have their individualized diet and strategies that they need. At the top, I tend to usually write something like if they need supervision, if they needed some one-on-one assistance with eating, maybe they need some cues for their swallowing strategies. Then we'll list their diet, what liquids they're on, if they should use a straw or not use a straw. I would say a lot of the patients that we see, if we are questioning any sort of penetration or aspiration, we're not going to want them to use a straw. Straws usually give you more volume, it makes everything move faster, so it's going to put you at an increased risk for aspiration. Strategies below for the patient, again, look at those, make sure you're using the right ones. And then at the bottom, we're going to say how they should take their medications. So sometimes that's going to be whole with liquid, whole with puree, might be crushed, could be all through the IV. It just depends kind of on what they need. I haven't been in the hospital for a while. I know we changed the color of cups. I think they're still the gray versus the maroon. So when we have those cups, one of them is going to be they're on a regular diet. Is it gray? Okay. So gray is typically what's in the room, and that's just going to be they're on a regular diet. There aren't any restrictions. We try to give them a maroon cup if we want them on thickened liquids. And that's just going to be another sign that when anybody's refilling their water for them that we know, oh, wait, step back. They're supposed to be on something different. Let's check that green sheet. We're going to be doing some swallowing strengthening exercises. And this can be for the oral phase. Maybe we need to strengthen the tongue or the cheeks. Could be any of the pharyngeal muscles as well. The goal for all these is to decrease that oral residue, increase coordination, and decrease aspiration. Okay? Now let's get into a couple of the different strategies that we might use. I kind of talked about them already, but the chin tuck, again, can or can't be helpful, depends. We usually try that one at bedside, and we also might try it during the swallow study. Double swallow and effortful swallow, that would be more for residue that we're seeing. Same thing with the alternating of the bites and the sips to help wash down that residue. Turning to one side, that can also be an appropriate one if I had someone that had a paralyzed vocal cord. It can help kind of compensate for that vocal cord that isn't wanting to move how it should. All right, diets. We all love them, or not. I don't know that the patients do either. But we're looking at these, and I'm trying to think, maybe a year and a half, 2 years ago is when we switched these, the names of all of them. So they used to be the National Dysphagia Diets. Now they've changed it to International Dysphagia Diets. I think the reasoning behind doing that is so that no matter where you go, you're going to be able to be on the same type of diet, and there shouldn't really be a question. Everybody, if it says soft and bite-sized, it's going to be soft and bite-sized. Anywhere else you go, you shouldn't have this huge variety of people giving the wrong things to that patient. If we're looking and breaking it down into the food versus the liquid, on the food side, it's just basically going to be a regular diet, obviously is the least restrictive. Then we would have soft and bite-sized with bread or without bread. You'll see that on the green sheet. We try to write it that way. Some people can tolerate chewing bread, but a lot of other people either have it sticking around on their tongue, they can't get it to the back of their mouth, or they could have a lot of pharyngeal residue with that. So just look at the green sheet for that one. Minced and moist would be the next restrictive, and that one kind of includes ground meat, canned or well-cooked fruits and vegetables, so really soft things. You don't want any peelings on them, nothing sticky. And then liquidized, essentially, it's kind of like puree. Over on the liquid side, we have a thin, or you could see us writing that as a regular. Mildly thick, which used to be called nectar. On this one, I think it's important to note that you don't want to give the patient ice cream or Jell-O because those things are water-based and they can thin out in your mouth, and then they could aspirate. Moderately thick, which used to be called honey, and then extremely thick. So extremely thick is like pudding. And I should tell you, I've had a lot of people ask me lately, how do I make pudding? Because if you look in all of the kitchenettes, they don't have pudding packets. It only goes up to a honey or moderately thick packet. So you would use 2 of those. Okay? On the extremely thick, magic cups are allowed. That is really what that consistency is supposed to be. We worked pretty hard, actually, with the dietitians to come up with some of these menus and guidelines for what our hospital is going to do. And then we placed all these menus in the kitchenettes in every department, on every floor. And so if you guys do have questions on those, let us know. but try to follow those the best that you can. Okay, let's kind of move away from swallowing and look at speech-language referrals. I guess we're still in the hospital. I better speed things up here. But as we're talking about speech and language referrals, let's look at the reason that we'd ask for one. They could have word finding, receptive or expressive aphasia, which receptive aphasia is really what you understand. Expressive would be what you can say or what you can write, how you express what you want to say. Dysarthria, and that is where you have trouble talking, but the reason for that would be muscle weakness, okay? Apraxia is also trouble talking, but for that it would be a disrupted motor production. So really by the time it's going from your brain to your mouth, there was a disruption in there, and then you can't get the words out. Facial droop, such as this lovely lady here, you might see on one side, or reading and writing deficits. So those are all things that we often may need to see. For treatment for all of these areas, I just kind of wrote down some examples. So for some speech treatment examples, we might try to have them slow their rate, increase their intensity or loudness. We might use something like a pacing board. And here's my low-tech example. So for a pacing board, if I literally just had some dots on a sheet, I might have that patient point to each dot when they're saying that word, and it can help them to slow down and use their motor movement to do it. We also do a lot of repetition tasks, just trying to help them hold that in their memory bank. For some language treatment examples, we have communication boards, letter or sound cues, sentence completion tasks. Okay, what does all that mean? Communication boards. Well, I worked really hard, probably at least a year ago. I'm trying to have communication boards placed at each nurse's station, at least one nurse's station on each floor, if not all of them. And this is one of them here. So it's a two-sided. I kind of liked it because it's got a lot of different colors to it, so it's easier for the patient to identify the pictures. The only thing I don't love is that it's smaller. So if they have visual deficits, this could be kind of challenging for them. But I like to have them there, especially if you don't have a speech therapist, it's a holiday or it's a weekend and it's evening time and a stroke patient comes in and they can't communicate. You want to find out if they're having pain. You want to find out if they need their family or a doctor. This would be a good place at least to start, to have something. All right, this person doesn't look like they're the brightest tool in the shed. So for a cognitive referral, these would be some of the things that we might see for that too. Memory, short term is typically what we see. I know you're loving the picture, Matt. I see that. Memory would be like short term, maybe they can't remember who just walked in the room or what they said. Orientation, why were you here? What time is it? What's the name of this place? Tell me some personal information. What's your address? What's your phone number? Especially when family said, well, they knew all these things just last week. I don't understand. Problem solving. So if they really can't figure out how to use that call button or that remote, the remote, I'll give them that. They're pretty tricky in the hospital. But can they find that button when they need to call the nurse? Safety, are they trying to get up when they shouldn't be? Sequencing, I've worked with a lot of patients. I've done home health, outpatient. I've done a variety of things. Sometimes I would see patients that tried to make coffee, for example, and they went to pour it into their cup and realized, I never put any coffee grounds in there. Or maybe they never even plugged in the toaster. So some of those sequencing things can be a challenge. And then attention. There's different types of attention. One, hopefully you're paying attention to me right now. That would be sustained. Divided attention would be doing two things kind of at the same time. So walking along while you're texting could be that. And then another one could be alternating attention. So you're sitting there trying to balance your checkbook. The doorbell rings. You have to come back and remember where you were. All right, what are we going to do for these people? Well, we're going to try some different strategies. We're going to give them some tools. Number one, maybe they need a little memory book. We might place that bedside. They might need a whiteboard. Using those whiteboards in the room in the hospital is really helpful for us, especially for orientation. I tell my patients, if you're smart enough to use it, then do it. It's not called cheating to me. So when a doctor or a nurse comes in all the time and says, what day is it? What time is it? Where are you? Look at the board. Look at the board. And if they look at that board, it's going to tell them the answer. It's going to help it stick in their brain every time they do it, better and better. Use a calendar. Sometimes we'll have them use timers, not so much in the hospital versus outpatient, but sometimes we can do that in sessions too. Some strategies we might use to make these functional tasks a little bit easier can include writing out steps, repeating, or simplifying steps. I actually had a patient just this morning. She and her husband kind of got into a little bit of a tiff, understandably. She came in, she had her walker, and she was sitting on it in the waiting room, and she tried to get up, and her husband said, "Come on, just get up and turn around, let's go." So she got up, and she turned around. Well, the walker was still behind her. She couldn't understand that she was supposed to turn around just her body, have the walker in front of her, and then continue on. So I quickly jumped in, and I said, "You know what, let's take this one step at a time. Can you stand up for me? Now I want you to look at your body, back up, turn, hold onto the walker. Now let's go." So sometimes if we can just break those down into simpler steps, that can really help with these patients. Next, we're going to look at voice referrals. This looks a lot different in the hospital than it does the outpatient side. In the hospital, lots of times we'll see people after they've had a trach placed. Okay, so in layman terms, looks like a hole in their neck. Okay, so it's going to help them breathe. So sometimes I might get called in to see if they can tolerate a passy-mirror valve. A passy-mirror valve is just this little valve. Usually ours are purple here, but sometimes they're white. It goes just on the tip of that trach, and then it can help them so that they can actually voice. They can have their own voice back. It may not sound like themselves, but at least they can talk again. Usually I'll start with having them see if they can do finger occlusion, putting their finger on the tip, and if they can and make some voice, I'm going to probably want to try a PMV. Okay? We get a lot of patients, obviously, in ICU that maybe were recently extubated, and they might have some residual voice deficits. It's pretty typical and common for them to have hoarseness and aphonia after they've been extubated, especially if they were on there for quite a while. But if it doesn't go away and those voice problems continue, that would be a time that you would want to call us in. Let's switch gears. Now we're going to look more at the outpatient setting. So we used to be up on the 6th floor of the old building, but a couple years ago, I don't know, everything blends together. But a couple years ago, they switched us over, so now we're in the basement. I have to ask my patients what it's like outside now, because I have no clue. We're in the basement of the Medical Arts Building, and we are with the OT and PT. We also have massage therapy. Plug. All right, so we have all of those together, and it's kind of nice. At first, I was a little like, whoa, what's going on? But now I like it, because if we get a patient over there that needs more than one discipline, we can try to make that happen within the same day, maybe even back to back. We see a lot of patients that have recently been discharged from the hospital for swallowing, speech, language, cognitive, and voice deficits. We also see patients that have maybe had a swallow study as an outpatient and they have a need for some treatment. We have one therapist over there right now that does see children with speech and language deficits. All right, let's talk about the differences. What would a swallow referral be like in the outpatient world? Well, maybe they had that video, and so now we have to help them with treatment. Maybe we have a patient that went to their doctor and they told their doctor, "I can't swallow my pills. I can't get food to the back of my mouth. The food or liquid is stuck. I'm coughing a lot while I'm eating and drinking." Maybe they just had an x-ray that showed they have pneumonia or a lot of lung damage and they can't quite figure out why. We also get, and we've been getting more, so I'm happy about that, head and neck cancer diagnoses. For these head and neck cancer diagnoses, it's important that we get these as best we can before they start radiation. There's stuff we can be teaching these head and neck cancer patients to get them ready, to get those muscles strong and keep them strong all throughout the radiation and chemo process. We talked a lot about this, what we do for swallowing in the hospital. So I guess in the outpatient side, I was going to talk a little bit about that head and neck cancer specifically. And some of this will apply to anyone that has swallowing problems. We'll do some swallowing techniques again. We would modify their diet. We'll do some strengthening exercises before, during, and after that treatment. But other things we want to really look at with these people is oral cares. And when I say oral cares, yeah, we want a clean mouth because we don't want, if they're aspirating their own saliva, we don't want to bring that bacteria in, which can actually cause the pneumonia. But also these patients can have xerostomia. What is that? That's dry mouth. So if they get dry mouth from all of this radiation, it can zap some of those salivary glands. And so then these patients have a hard time swallowing because they don't have any saliva. So we're going to try to talk them through, what can we do to try to help them with that? Maybe some biotine. There's just different strategies we can give them. Also, we want to monitor for trismus. I know it sounds like Christmas, but it's not an enjoyable thing. Trismus is when they have a hard time opening their mouth. So after radiation, it can cause kind of a constricted mouth opening. And I've had patients come in that are literally trying to eat with a baby spoon. They just can't open their mouth wide enough. So I will take some measurements. If I get them before treatment starts, that would be awesome before radiation, because I can see where they're at now and what's happening throughout that treatment and after treatment. And then I can give them some more tools to try to help get that mouth opening again. We're going to work closely with a dietitian, because a lot of these patients that come to see us, while they're undergoing these treatments, they have a loss of appetite. Maybe their mouth hurts because they have sores in their mouth. They're going to say it's really hard to swallow. And so for all those patients, we've got to help them get the biggest bang for their buck. How can we increase their protein and their calories so that they're not getting weaker and weaker and losing weight? We also have a Mcniel dysphagia therapy program. And this encourages daily food trials, but with strategies that we give them in speech therapy. Really use those muscles as best we can. Okay, this next one's also kind of my love. So I like voice. So for voice referrals, we get a lot of people. My husband is a coach. I get on his case all the time. Teachers, professors, singers, and coaches, sometimes they're naughty. So they may end up with a nodule or a polyp because they talk a lot. They might not be good to their voice. They might not be drinking a lot of water. And so what can happen over time is they can get these nodules or polyps. It's essentially like a little bump on the vocal cord. And then when your vocal cords try to come together to have you talk, it really affects you and you can become breathy. Okay, it really affects your vocal quality. So we have lots of exercises that we can try to help them bring those nodules back down, get that swelling down off of the vocal cords. We also work with vocal cord paralysis, vocal cord cancer. Maybe they have reflux that's caused some edema. Difficulty breathing with exertion. That's called vocal cord dysfunction, and I'm getting more of those too. So that would be some of our athletes that we get. Maybe they're runners, and all of a sudden they feel like they're going to pass out. I've had some coaches actually call me and say, what do I do? We were going to call 911. I'm not sure how to help this girl. She can't breathe. So that's periods where maybe their vocal cords need to relax so that they can get the air that they need. Okay, so we have different exercises for that. One important thing here is if we do have a doctor referring to us, there's some insurances, for whatever reason, that are requiring an endoscopy to be completed prior to getting speech treatment. Otherwise, they're not approved. So my guess would be that they really want to see that there's a problem that we're treating. Some other voice treatments we do, and especially for Parkinson's. So there's a big Parkinson's population. So I want to talk a little bit about Lsvt Loud. And that is a 4-week intensive program, 4 days a week, 4-week program, has extensive research specifically with those Parkinson's patients. We also have purchased the Lsvt Companion that we can use. It's a computer system, has a microphone. We're also able to monitor a distance between their mouth and the microphone, have that distance so that when we're doing our exercises, it's going to be consistent from therapist to therapist and session to session. What we're working on is we're really trying to help increase the loudness of their voice. There's another one similar called Speak Out. It's very similar to Lsvt Loud. And then we think that either of these are a great combination with our Lsvt Big. So in physical therapy, they may be doing big movements, really trying to help those Parkinson's patients because oftentimes they kind of shuffle and they're just not doing those big movements that they need. So if we're trying to work on opening that mouth, projecting that voice really powerful, then they're also trying to do it with the body, and those two going together can be really beneficial. Which, by the way, we have both. So coming to see us, if we can pair them back to back, would be awesome for that patient. All right, what are some other voice treatments we have besides those? For my coaches and teachers, I try a lot to have them use voice amplifiers. In the school systems, I ask if maybe they can put one of those into their classroom. That can help them take some of the pressure off of using their vocal cords. We also teach tension reduction exercises, so getting rid of any tension around the voice box. Myofascial release exercises. These are more hands-on. So I do a lot of that. It can help bring down any sort of lymphedema that a patient might have after radiation treatment. Voice exercises for gentle phonation. So that means exercises to help kind of vibrate those vocal cords, getting them moving, but in a gentle way. Vocal cord adduction exercises. So adduction means bringing together. If I have a patient that has a paralyzed vocal cord in an outward position or bowing of the vocal cords like this, and we want them to come together, we're going to work on exercises to bring those back together. We're going to work closely with an ENT, especially if we're questioning any reflux, vocal abuse, or dry mouth. And for those vocal dysfunction patients I talked about, the runners that are having a hard time breathing, we're going to be teaching them some strategies to use while they're doing an activity. So if I have a runner and they're having a hard time, I'm going to put them on the treadmill, teach them a strategy, and when they're having that problem, let's see if it works. All right, speech and language referrals. This would be if they have a facial droop, stuttering, word finding, dysarthria, apraxia, receptive or expressive aphasia, or reading or writing deficits. Also, those children with the speech language delays, like I said, would be seen in the outpatient clinic. The speech language treatment that we can provide over there, if it's a person, for example, that's had a stroke, and it's a pretty significant stroke, then we're going to be seeing them for quite some time, as long as they're still making progress and there's still a need. We're going to be doing reading and writing tasks, maybe naming a lot of different items, speech intelligibility. We're going to work on those functional tasks to increase their independence both at home, in school, at their job, and in the community. And we have a speech therapist, again, that works with children on those things. In our outpatient clinic, we have developed, in the last couple of months, a stroke team. So that's going to consist of OT, PT, and speech, who are all going to work together on a plan of care. We have some different standardized assessments that speech may be giving, including the Boston Diagnostic Aphasia Exam, the Western Aphasia Battery, Cognitive Linguistic Quick Test, the Ross Information Processing, and the Assessment of Language and Functional Activities. We also want to do care conferences frequently. Involved in those care conferences would be all of us as a team, also a patient, family, and we're going to talk about the plan of care, maybe any evaluation results that we got, goals, progress, any discharge plans, and then answer any questions that they may have. All right, cognitive referral in the outpatient world. It's kind of the same type of deficits we'd see on the inpatient side. So it's going to be those memory orientation, safety, problem solving, attention, and executive functions. These are some of the diagnoses that we may see associated with cognitive deficits. A CVA, traumatic brain injury, a concussion, or a motor vehicle accident. In the outpatient side, I really try to help these people get back home and be as independent as possible. So it's a little bit different. When they're in the hospital and I only get to see them for a couple days, I'm working on safety within those few days, safety with swallowing. Remember these strategies just for here and now, because I don't have them very long. When I get them on the outpatient world, I'm going to be trying to teach them stuff that'll stick with them to remember daily activities, maybe taking their medications, things like that. So we're going to discuss internal and external strategies for memory. On the internal side, so that's going to be stuff in their head that they're going to want to pull out and use. Maybe they're going to be able to repeat what they're supposed to do. Associate. I can remember at one of my old jobs, we had this head of nursing, and her name was Amber. For the life of me, I can't remember names. I'm terrible at remembering names. And so every time I'd see her, I'm like, what is her name? I need to talk to her. I looked at her hair finally one day, and it's kind of this like amber color hair. And so I was like, Amber, that's it. So from then on, every time I saw her, I could recall, I associated it with that color amber of her hair. I got it from then on. Storytelling. For example, if I gave you 3 words, tree, bird, and food. Okay, I'm supposed to remember those for how long? If you can make up a story, so the bird flew from the tree searching for food. We'll try to work on that storytelling strategy and see if then they can remember those words. I'm going to give strategies to increase recall for daily activities at home and in the community. I'm working with a few patients right now, and one of them she can't ever seem to find her keys. I'm sorry, am I going over? I'll stop soon. Okay. So she can't ever seem to find her keys, and so we're working on how do you keep track of things. So if she puts her keys kind of right on a hook by the door all the time, that is just a normal place. She's always going to keep them so that if she's looking for them, that's where they should be. Same thing with like a telephone. If she always puts it by her bed or by this recliner in the living room, that's its place. That's where that should be. We'll have them set timers often to take their medications. That can help so that we know they're actually getting them on time. We're going to discuss strategies for increased safety and problem solving at home. All right, the last area that I'm talking about is augmentative therapy. So for this referral, this is when a person we can't find any other means for them to communicate. They can't write, they can't talk. We need some way to help these people. It could be from primary progressive aphasia or a stroke. I showed you the communication board, but there's other ones. That was a low-tech. High-tech ones would be if they can actually use an electronic device, and we work a lot with Talk to Me Technologies. There's other companies as well, and we're going to try to have them push these buttons in order to be able to communicate with us. We're going to work with the patient, the family, possibly staff if they come from a group home, to try to edit this device, and we want to help them navigate through using this. Pre-COVID, I would have them lots of times go to a restaurant. We could maybe take them over to the cafe and see if they could order some things. Right now, we do a lot more just within our clinical setting. We got to also think about, can they read? Do they need words on it? Do they need pictures? So those are all different things that we really have to assess so that we're giving them the right mode. Okay, in summary, Mary Greeley has speech-language pathologists for inpatients, outpatients, home health, and acute rehab. We assess and treat a variety of disorders, including voice, swallowing, speech, language, and cognition. My hope is that after this presentation, you might know why you should place a referral for each of these areas, what are some evaluations we may do, and what are some treatment strategies. I want to say that I enjoy working here at Mary Greeley in all settings because I just feel like no matter where you go, it's a team. I don't care which floor I'm on, which department I'm in. I feel like I can talk to the nurses, talk to the doctors, and we all are just trying to put the puzzle pieces together to best help our patients. All right. Questions? Oh, I think Tim is doing this. None? It was that good, huh? Do you guys have any questions? Okay.
If anyone has questions, please type it into the questions box.
Do. Okay. Well, if anybody ever does have questions, please feel free to talk to any of us. I feel like we're all pretty open and we'd be willing to help in any way. Thanks.